Hello friends. In our last video, I have discussed about the paroxysmal supraventricular tachycardia in just a nutshell. Now today coming to a detailed discussion about the supraventricular tachycardias, we'll mainly deal with the AVNRT or the AV nodal reentrant tachycardia. Now as the name of this channel is NEET PG concepts, we'll be focusing more on the concepts because you can easily find any X or Y channel and you can know all the knowledge from take all the knowledge from there, but our focus is on to be a different, something different. We will try to solve the concepts of the PG students, of the students who are going to do the PG and who are facing the entrance examination, so that when their concepts are clear, they'll be able to solve multiple questions based on those concepts. So coming to our supraventricular tachycardias, now आप सब जानते हैं supraventricular tachycardias जो होते हैं, firing of the heart is normal. Why do these happen? So suppose a premature atrial contraction or PAC comes. Normally it comes. We all have premature atrial contraction, but it doesn't lead to any tachycardia. Then what happens? Why is this? Why this leads to tachycardia? Now there is a very interesting physiology behind this. That we all in our normal hearts, in our AV node, in the node there are two pathways: the fast pathway and the slow pathway. Normally, when an atrial impulse from the SA node comes, it travels via the fast pathway and via the slow pathway also. And the fast pathway conducts to the AV node to the bundle of His, and the slow pathway also comes, and these both pathways, they cancel each other. Now what happens? Sometimes the premature atrial contraction comes, then this comes along the slow pathway, it enters the fast pathway, and a circus movement is formed. Now why this circus movement is formed? Because the fast pathway in the AV node has a longer refractory period, and the short pathway in the AV node has a shorter refractory period. So when the premature atrial contraction arrives and the effective refractory period of the long pathway is ended, then it again moves into the long pathway and a circus movement is formed. And what happens? And there is an upward current towards the atria, and there is a downward currents toward the ventricle. So the ventricles are depolarized. Ventricles are depolarized below this circus movement, and the atria is again depolarized retrogradely. So what happens? This you must have seen that the P waves embedded P waves in the QRS complex. There is a finding that you see that P waves will be embedded in the QRS complex at the end of the QRS complex. So this is very interesting physiology behind this. I hope you must understand this, and don't confuse AVNRT, AV nodal reentrant tachycardia, with AVRT, ventricular reentrant tachycardia, in which the aberrant circuits are there in addition to the AV node. Don't confuse with that. Now friends, as you know that AV nodal reentrant tachycardia has three subtypes: the fast slow pathway, the slow fast pathway, and the slow pathway. We will not go into details of this because they are not asked in the PG examinations, but what is asked in the PG examinations is are these classifications and basic knowledge of these things and how to manage a basic PSVT. So we now moving towards the classification of the supraventricular tachycardias. Now when this classification will clear your doubts regarding various questions which will come into your NEET PG examinations, that you see that everybody takes that the tachycardia will be irregular only, or no, it may be regular also. So there are regular tachycardias like sinus tachycardias, and irregular like atrial fibrillation. Atrial fibrillation is a very favorite topic of all the examiners. So आप ECG देखेंगे, ECG there is no P wave, तुरंत आप atrial fibrillation मार देंगे, but P waves are also absent in paroxysmal supraventricular tachycardias, AV nodal reentrant tachycardias. And what is most important between differentiating features between atrial fibrillation and AVNRT, that it will be a regular tachycardia. AVNRT is a regular tachycardia, and atrial fibrillation will be an irregular tachycardia. So what is the classification? Now coming back to the classification of the supraventricular tachycardia. So they are regular tachycardia, they are sinus tachycardia, atrial tachycardia, atrial flutter, and inappropriate sinus tachycardia. Now irregular atrial tachycardia. What are these? Atrial fibrillation, atrial flutter with variable block, multifocal atrial tachycardia. So these are the tachycardias. Now coming back to the clinical features, which I think we should discuss very briefly. AVNRT is a very common cause of rapid regular palpitations, heartbeat more than ranging between 140 to 280 beats per minute, and clinical features range from you can get palpitation is one of the clinical features, then syncope, pre-syncope, chest pain, dyspnea are the clinical features. Now ECG features you must notice what are the ECG features. The ECG features you see that it is a narrow complex tachycardia with the QRS complex less than 120 milliseconds and absent P wave. Actually the P waves are not absent, they are embedded in the later part of the QRS complex in the 90% of the cases, because 90% of cases the fast slow pathway is present. In the slow pathway, in the slow fast pathway, you can see the P waves in the just before the QRS complex. And now one more important thing you must notice, that why this premature atrial contraction happen. Now these can happen due to exertion, excessive caffeine intake, then alcohol or beta agonists like salbutamol, etc. So these are some important causes. Now these are the atrial tachycardias. Now regular atrioventricular tachycardias, these are AVNRT and AVRT. Now AVNRT we have just dealt, and AVRT will deal in a later episode because it's a vast topic. So now the management also has been asked about these supraventricular tachycardias, and everybody knows that the first thing is if the patient is if the patient is stable, then we'll do vagal maneuvers, and adenosine is the vagal maneuvers, and then adenosine. If vagal maneuver is not in the option, then adenosine. Now calcium channel blockers, amiodarone can be also given, and if the patient is unstable, then DC cardioversion, which is rarely required, can be done. And the permanent treatment not responding to medical treatment is catheter ablation of the foci which are causing these tachycardias. So hope now this topic will be clear to all of you, and meet you in the next episode.